Okay, we are going to speak about calcium of peripheral arteries and how we can overcome the problem of big calcium burden. And can I have the first slide? Excellent. Okay, so we continue about the orbital atherectomy. What about the disease state prevalence? In fact, is quite high, and you probably know that the peripheral arterial disease is one of the biggest predictor of mortality, and the majority of the mortality is due to cardio and cerebrovascular accidents. So it's one of the biggest marker for atherosclerosis per se. So it's very important to recognize on time and to treat on time the peripheral arterial disease. Unfortunately, the risk factors among the patients with peripheral arterial disease are multiple. In the most of the situation, they have higher age, diabetes, kidney disease, and smoking. That is also worsening the risk profile. And unfortunately are complicating the way of treatment, surgical or endovascular. And speaking about endovascular, the biggest enemy of endovascular intervention, both on coronary and peripheral arterial disease level, the biggest enemy is calcium. So in order to have good vascular result, coronary vascular or peripheral, we have to have a good vessel preparation. And after having a good vessel preparation, we can do everything, anything, balloon, drug-eluting balloon, stenting, whatever. But the most important, in order to achieve good late result, is to have a good vessel preparation. And the calcium is like shown here in the IVUS, and how Valery was showing during the symposium of TEVA during the IVUS investigation. In fact, the calcium burden is one of the biggest problems of overcoming and to prepare the vessel, especially the circumferential calcium. And like you can observe here on the right panel is almost circumferential with only one spot without calcium. And speaking about calcium, the prognosis and the consequence of peripheral artery disease are also not good. So not only the intervention is difficult, but also the prognosis is not good. And this is very important to emphasize that the increased adverse event and decreased drug-coated balloon success, it's obvious because there is no contact, in fact, between the drug, between the balloon and the intima, because the calcium is there and doesn't allow any elution to improve the results, the late results. And definitely, like stated here, we have much lower stent success. So the compressed stent in our daily practice is definitely one of the biggest problems. And you know that in such a situation we have some bailout options like shockwave. But it's not good not to prepare the vessel in order to overcome after that not well expanded stent. So the most important is to prepare the vessel. Speaking about calcium, historically, you know very well that the rotational atherectomy is the first one by historic point of view. But orbital atherectomy is the most modern and more advanced. I will try to show in what means more advanced technology. In fact, the orbital atherectomy, one of the main advantages for me, by my point of view, is the orbital atherectomy is bidirectional. So the orbital atherectomy burr, you know, it's the diamond particles are only up front and not behind, and because of that it's much a bigger probability the burr to be stuck into the artery and not to because of the calcium not to have the possibility to remove it back. And this is very important and very unpleasant situation in coronaries, but also in the peripheral artery is not a good situation. So it's a percutaneous orbital atherectomy system indicated for use as a therapy in patients with occlusive atherosclerotic calcific containing lesions in nowadays practice. I already mentioned vessel preparation, how important. In fact, part of the vessel preparation is not to remove the calcium. The most important to change the compliance of the vessel. So even if performing only cracks without removing all the calcium plaque, it plays a very good role about the compliance of the vessel in order to have good balloon dilation and good stent expansion after changing the compliance of the vessel. And you can see the comparison without and with atherectomy, with the orbital, how important it is to have this in the practice. The superficial calcium is sent by diamond servers, and this is the, in fact, in this video, it's also, you can in fact see what is also the other difference with the orbital atherectomy. The other difference with the orbital atherectomy is the centrifugal and also rotational ablation of the calcium, not only rotational. So it's based on a carbon block model. More than 93% of particulate, smaller than a red blood cell. And this is very important because the probability of slow flow, stagnation, blockage of the microcirculation is very low because of these very fine particles that are produced by the orbital atherectomy execution. Okay, this is the same, showing how the particles are much smaller compared to even to the red blood cells. So they are going through the microcirculation. And this is in fact on the bench test how the things look like. You see the eccentric crown delivers a localized mechanical pulsatile force into the vessel wall. And the pulsatile forces may contribute to the compliance changes seen with the orbital atherectomy that I was speaking about. And this is the centrifugal force. By the way, this is part of the protocol. The centrifugal force is increasing with increasing the speed of the rotation. And on such a way, in fact, it's increasing the volume of calcium that is removed, and definitely the resulting lumen. The resulting lumen is increasing with the increase of the speed, like was shown in this figure. So these are the. Is it a movie? Can you play the movie, please? Great. Thank you so much. So. This is the schematic of what I'm telling about. You see over the wire. It's a detail. It's better to have at least some patency in order to cross with the wire. Some colleagues are using also for CTO, chronic total occlusions, but yeah, it's more challenging. It's more challenging. You see how the centrifugal force, in fact, movement is creating the lumen itself and making particulate that are going further distally and crossing the microcirculation without any problem. Next slide, please. Okay, this is before and after the orbital atherectomy. You see that not only the vessel is bigger, the lumen of the vessel is bigger, but also there are some cracks. You see, there are some interruptions of this calcium mantle, and these cracks are very important speaking about compliance of the vessel, like shown here in the video. And so this is crucial for ballooning and stenting during a particular procedure. The clinical data, they are gathered a lot of clinical data nowadays on different vessel levels, femoral, below the knee, popliteal, and so on. And these data are very encouraging and very promising for the utilization of the orbital atherectomy in the future, improving the situation, the amputation, reducing the amputation rate, increasing the patency rate, decreasing the instant restenosis, and they are randomized and registry trials. For example, the study design over 200 hospitals, over 350 physicians participating, treating almost 4,800 lesions. And these are the data, the balloon inflation after the bailout stent procedure. You see that it's quite a low rate of bailout stenting. It means the protocol of orbital atherectomy plus ballooning with a non-compliant balloon and drachylutein balloon, it's quite well working scenario, and because of that the bailout stenting is very low, up to 10%, not more, even staying at around 5%. These are the 3 years result. This is also very important to emphasize that the calcium is one of the enemy for longevity of the results. So this is also very important to show. And I mentioned that the amputation rate is lower with the orbital atherectomy preparation of the vessel. And you see from baseline to 2 years in all groups how significant improvement in Rutherford clinical class is the result of orbital atherectomy. Of course, quality of life, it's very important. During the last several years, the quality of life is a very important endpoint, not only the so-called big firm endpoints. In a summary, the dual mechanism of action for orbital atherectomy consists of differential sending and pulsative forces. Vessel preparation with orbital atherectomy results in a compliance change. Compliance change enables lower pressure balloon inflation, and inflation results in low complication rates, including dissections. This is also very important because it's one of the in fact, factors that can lead to bailout stenting, and the result of multiple clinical trials show the orbital atherectomy is a reasonable treatment option. One of our cases, we had in total very limited initial experience. It's a 77-year-old man with multiple risk factors and multiple interventions in all the vessels of the body, carotid, coronary, multiple times, heavy smoker. He didn't want to smoke in any moment in his life. And you know that the smoking is one of the biggest predictor of peripheral artery disease is smoking. So in this mediocalcinosis, very big calcium burden, you see in this initial picture, initial video, you see all the artery is visible without contrast. It's the so-called calcium roadmap with a very short claudication. And this is distal, in fact, the popliteal, on the level of the popliteal artery collateralization. So our strategy was finally, after many attempts to do ballooning, we finally, after the restenosis for 4th time, finally we decided to go with orbital atherectomy. And the other, one of the details, it's very important, orbital atherectomy to be performed slowly. So not on the fast way like the rotablation, but it's much more predictable with small steps, let's say millimeter by millimeter. And it's also very much more predictable to achieve good lumen with this slow motion, and this is the final result. You can you remember the SFA, how calcified and practically totally occluded was after multiple restenosis situations, and this is also below the knee with excellent, very fast flow. The follow-up was very good, and he started, of course, complaining from the other leg, because the right leg was on an excellent way treated, and we did the same procedure for the left, with the difference that on the left side we had to implant a stent after the orbital atherectomy, and the expansion of the stent was absolutely excellent after having the orbital atherectomy preparation of the vessel. This is the ballooning and stenting with excellent result finally. And we used this procedure to check, it was 3 months after the first, we used this procedure to check what was the result, 3 months result of the right one. And this is in fact the check of the 3-month result on the right SFA that we have treated before. Before you see that is practically almost the same like the final injection, almost like the final injection on the previous procedure. And with that, yeah, this is the CT, shown very good patent bilateral, and thank you very much for your attention. In fact, this is the burr. You see, here is the console to move the system, and this is the burr itself. And this is the burr, and it's longer compared to the rotablation. And as I told you, it's bi-directional, so it's abrasive, not only going further, but also it's abrasive going on the way back of the artery. And this is the console, and it's quite user-friendly, I would say. It's the knob is very comfortable. So, questions, comments?
Yeah, I think congratulations, Ivo, is extremely nice work, and so I would have a lot of questions, of course. But so first, we do a lot of coronary atherectomies in coronaries, and we do more backward ablations. Do you think that is important in peripherals also? Because slow is okay, everybody must do very slowly. Yeah. But do you see any impact in backward ablation, not just forward ablation?
In fact, I like very much going backward, because also it's telling us if the patency is good. In case we have some resistance on the back, on the movement back, definitely we have to continue to make one more pass, second pass, third pass, and so on. And this is pairing contrast, definitely. And after having, in fact, it's incremental increasing of the speed in order to have incremental ablation of the inner part of the calcium. So we don't go directly to the highest possible speed. We are starting in order also to avoid complications, obviously. So we are going with a lower centrifugal effect on the lower speed, and going stepward, going up in order to increase the result. And I'm using on the same way, slowly going back, because it's also the abrasive effect on the vessel wall.
Okay. Thank you, Ivo. It's very good that we have dual devices in our armamentarium, and it's really important for the patients. But